acknowledgement that I want to make as our banner on the wall states, this is Native American Heritage Month, and we are on Tongan ground, and I think we should just do some honor to the folks who came before us. We don't do that enough.
Thank you.
And one other piece, I was asked to structure my comments. I guess in the past maybe I wasn't focused enough, so I've taken...
No, I'm sorry, it's not you not being focused enough. We were peppering you from all different angles with our various interest areas. We wanted to make it more easy to understand in buckets. So
okay.
Thank you for helping us out.
Well, I've structured it as asked. The budget's already been covered by Dr. Sharon, and we'll have more about that next month. I'll then talk about organizational structure and some key appointments. Then I'll talk about updates that center around programs and services. And then I'll talk about some contemporary problems and issues that we're facing. And then last, there are a couple of follow-up items that I'll talk about. So I mentioned about Native American heritage. One person in the department who many of you may not know is a young physician by the name of Andrea Garcia. She is not a psychiatrist, she's actually a rehab physician specialist who was hired a little over a year ago, shortly after I started. And this is in part due to her advocacy for the Native American Alaska Indian community, where she had done work with the American Indian Commission. I forget the exact name for it, but it's the equivalent of this commission, but it focuses on Native issues. And she has been I would say, breath of fresh air in helping our clinicians to understand, in addition to our one AICC clinic that focuses on American Indian issues, to think about Native Americans and how they are disproportionately represented amongst the homeless and how they have needs within our services that we don't always meet. So I think at some point, she's a subject matter expert. We're also working on bringing on board, or actually transforming an employee that we currently have who is going to be focused on LGBTQ+ issues, as well as women's and reproductive health issues, which is something that's been neglected or hasn't had its proper place within the department. So having these types of clinical coordinators are really a part of us transforming our services to meet the needs of the people that we see in our clinics and also throughout our system. There are two key appointments that I'll mention. I think some of them we've been talking about, they've been long coming, but now I have names to put to the positions. The first is a deputy director for countywide engagement services. That division is now under the leadership of Latina Jackson, who some of you know previously from Service Area 2, where she was a Service Area Chief. Ms. Jackson is a passionate advocate and a frontline provider who's had numerous positions within the department, but as Dr. Sharon talked about, the home team, the amalgamation of several teams that do outreach to the most vulnerable will fall under her jurisdiction. That will include AOT, the home team, the folks who are really, I would say, at the periphery, who we're trying to still engage, who aren't yet quite engaged with services. So we'll be looking to cover Service Area 2, so there will be an announcement that will go out in a recruitment to get a Service Area Chief for that area. The second announcement is a Deputy Director for Housing and Job Development Division. Again, we spoke a little bit about that earlier, with employment being a component of that position. The person who will hold that role will be Maria Funk, who some of you know has already been our housing guru. Maria's been within the department for quite a long time and is a policy and practice guru in housing and employment in that space. This is a newly created position and she's exceptionally qualified. It will be under the administrative side of the house, but I've told Maria that my door is always open because we expect that between Maria and Latina, given the needs of the seriously mentally ill and housing, that those two positions will work closely together. Just to talk about where we are with the department, we go through a complicated budget cycle. I'm a year and a half in now and I'm still learning more about it, but one of the things that I learned is that my staff have I would say, substantial desire for more help. And because everybody feels like we should and can be doing more, so we started out our open discussions about what are the asks within the department. And between the clinical services that report to me, there was a total of 750 positions that people wanted. I had to curb their enthusiasm a little bit. We're a department of 6,000, and although we've grown substantially over the last 2 years, that kind of ask just wasn't practical. So we did narrow it down, and there were 274 positions that we did request in the upcoming budget. But one of the things that we were told is that because of our number of vacancies, we have to make these positions mostly offsets, meaning that if there's a position that's been vacant for a long period of time, rather than hiring and making a new position, we hire against that position and if need be, fill behind it or replace it later. With that, I would just point out a couple of the key programs that we are increasing or have requested increases in size. One of them is the mental health court linkage program, which has been fairly small, I would say, since my beginning with the department. I was shocked that it wasn't, and we weren't in more courthouses. We've also requested 90 staff just for the directly operated clinics so that they can meet access to care needs, so that they can see people not only at the time of intake, but also provide appropriate follow-up care. And we've asked for funding as well for positions within emergency outreach and triage. I'll get to that in a moment, as well as within the pharmacy where we want to have 15 FTEs. We now have clinical pharmacists. A few of them have been hired and are rotating in our clinics to help with medication management and more complex patients with medical needs. So the growth overall is something that continues to happen in the department, and it's a daily struggle with HR and the CEO trying to get people into the front door. One other successful hire that we've had, and I'll highlight this one because it does represent, again, a change in our structure. Dr. Danielle Smith-White, who came to us from Jail Mental Health Services, had previously worked at our San Fernando clinic, where she has now returned as the supervising child psychiatrist. We now have 2 positions that are new, that are supervising mental health psychiatrists that focus specifically on children. There is one who's already been Associate Medical Director, Dr. Karen Lee, who works for the south part of the county. Dr. Smith-White will cover the northern counties, and she is also serving as the program head at San Fernando, which is a new position for a psychiatrist to hold. Dr. Sharon and I both feel strongly that while there are many types of leaders, one of them that we shouldn't forget are physician leaders. And so she will be working with the staff there to manage what is a relatively small program and also oversee the child psychiatrist and be a subject matter expert and work hand in hand with the Deputy for Child Welfare to provide expert advice and consultation on difficult cases. I'll move on to updates about programs and services. And this was something that I can bring you some good news. One of the things that we do annually is the External Quality Review and Oversight Committee, EQRO as it's affectionately known. During this last visit, we were told that we had some challenges with meeting what's called network adequacy. And this is having enough providers of each type to serve the different populations that we need to serve. But I'm happy to report that after the technology folks went back and looked at the numbers and got all of our providers to submit their information, we were at over 100% adequacy for all of the different categories, which include psychiatry for those who are 0 to 20, child psychiatry, we're at 113%, for psychiatry for adults 21 plus, we're at 165%, for outpatient 0 to 20, we're at 113%, and outpatient 21 plus adult at 125%. There are actual numbers that go with the number of providers. For psychiatrists, it's in the hundreds. For other therapists and counselors, it's in the roughly in the 2,000 to 3,000 range. So I think we now have, at least on paper, enough people to do the work, but we had to adjust the submission because we have to make sure that we're not overcounting hours when someone reports them that everything is accurate. But we do have about 10 psychiatrists in our system who are willing to work more than 40 hours per week. Last night I attended a faculty meeting at Charles Drew University. Some of you know that one of my jobs before coming to the department was as chair of psychiatry there. I maintain a faculty appointment, and quarterly there is a Department of Psychiatry faculty meeting and also a general faculty meeting. I'm happy to report that we now have 12 psychiatry residents who are training in coordination with Charles Drew University, funded by DMH. They rotate through some other areas as well, including the VA, but the bulk of their work when they get to their outpatient services will be in DMH clinics and directly operated and